Everybody to our September Echo series. I'm Kathleen Wellman. I am the program coordinator and Echo lead for the Constellation Regional Collaborative. We just wanted to welcome you to our series and thank you for joining us today. Today we have a great presentation coming up. We're going to do just a few introductions real fast. We'll have our didactic presentation and case review by Valerie Perez. Some questions and discussion after that. We'll talk about what's happening next session and for the future. Then we'll just discuss a little bit about that post-echo survey and have our closing comments. For introductions, we would love to have our subject matter experts introduce themselves. And while they're introducing themselves, if we could have our participants in the chat, please share your name, employer or organization, and your position credentials. That way we can all get to know each other. Sydney Fleming is going to be taking care of our chat like always. And so if you have any questions, you can feel free to ask questions to her too in the chat. So I believe today the only SME that I saw, because I know there were quite a few scheduling conflicts, was Emily Ridley. If you could introduce yourself, please.
Sure. Hello, everyone. My name is Emily Ridley. I'm a clinical pharmacist based out of an internal medicine residency clinic within Prisma Health in Columbia, South Carolina, where I serve primarily low-income urban population, but we have a lot of rural patients as well. On a daily basis, I work with our patients in helping improve hypertension and diabetes control. I've also worked with our health system in quality improvement efforts regarding hypertension control and served as a consultant with PAHO with the Hearts of the America program. Glad to be here today and looking forward to the talk.
Thank you, Emily. We're so happy to have you. Our other subject matter experts, like I said, did have some conflicts with either conferences or other meetings or patients. So they were unable to join, but they will catch up with the recordings in the future. And at this point, oh, I'm so sorry. At this point, I would like to go ahead and transfer over to Valerie Perez, our didactic presenter.
Hello, everyone. So I'm going to share my screen. Okay, wonderful. Okay, so today we're going to talk about how we're able to bridge the gap between hypertension and cardiovascular risk within the unhoused population. And I am Valerie. I'm located in Florida. And part of my work really stems around system coordination over the last 15 years within the homeless response system here in Central Florida. And I have a very strong focus in youth collaboration and developing advisory boards consisting of people with experience and program design and implementation. So one of the interesting things here in Florida is that our weather affects us a lot more, as affects our unhoused population a lot more than we like to realize. But there's also an additional risk that happens, is that chronic illness becomes such a main contention amongst our unhoused individuals. And within Florida, they face about 2 to 3 times higher risk of chronic illness and premature mortality compared to the general population that is currently housed. So just a little refresher. Cardiovascular disease includes conditions like heart attack, strokes, and heart failure, and it's the #1 cause of death within the United States. And then we also have hypertension or blood pressure. Sorry, I'm trying to move the controls out of the way because they all are popped up a lot. So it's one of the biggest risk factors for cardiovascular disease and is often called the silent killer, because people can have dangerously high blood pressure without any obvious symptoms until a major event happens. within our population in Florida, we are seeing such a high risk of medical issues that hypertension has become one of the leading diagnoses amongst our population. And we're seeing anywhere between 40 to 60%, and the number is increasingly getting higher to that 60% and surpassing it depending on which county or part of the state that you're in. And it really showcases the limited access that unhoused individuals have to proper medical care as well as consistent care, because that is the key. With the limitations we have within Medicaid or Medicare within Florida, that has really impacted our population's ability to get consistent, organized care. Some of the risk factors that our unhoused population experiences, and this is applicable throughout the country as well, is social determinants of health. Chronic stress, anyone's exposure to violence, being in that survival mode, worried about where you're going to sleep that night or if you're going to be safe there and go somewhere else the next day. That is a consistent rolling thought of stress that increases someone's blood pressure. And then there's also food insecurity. You never know when your next meal is going, like where it's going to come from or what it's going to consist of. Some of our unhoused population go days without eating, or if they are able to eat something, it's typically something that's high in sodium, so like chips or candy, things that provide immediate sugar and glucose spikes versus something that is a long-term withstanding within the body for digestion. And there's also a potential of limited physical activity due to unsafe environments. So within the state of Florida, we do have the encampment bans where individuals are not able to stay within one location and kind of find their own security in a location anymore. So that has also impacted how the navigates a little bit when it comes to social support. And then there's medical access barriers. There's a lack of primary care and consistency amongst that. And the reason is because they are transient. They have to find their safest location, like the primary focus is where they're going to sleep at night. It is not really their medical self. It's not really their mental self or their emotional self. It is housing and where they're going to be, if they're going to be safe. And then there's also the cost of medication. If you're currently unhoused and you do not have enough for your own personal care of food or your personal care of yourself, there's a higher correlation to the fact that the individual will not be able to cover the cost of medication or any type of additional prescriptions. Plus, with being transient in nature, if there is a location when someone is not currently there and like their tent and personal items are in a location, and if that space gets cleared out, those items, those personal belongings go into the trash. It is not stored, it is not cared for. So there's a higher potential factor of not being able to keep your prescriptions, or they get stolen, or they get damaged or tampered with inadvertently. And in some cases, depending on someone else's intentions, it can be intentionally manipulated. And then there's a higher reliance on emergency room care for various crises, and also in some cases prevention. So if they know they've been without medication after they've been diagnosed with vascular disease or hypertension, there's a likelihood that they would go to an ER just to get a kind of like a status overall check to see where they're at and if they're able to get some immediate support. There's also a higher rate of diabetes and substance use and smoking within the unhoused populations. And it's part of the first two factors. Chronic stress increases your cortisol, which then increases your entire functioning of within your physical self. And as someone who is diabetic and has also previously been unhoused, I can guarantee you this is one of the ways of one of the things that we're also seeing more within the population as a provider as well, that it is a very strong correlation that if you're unhoused and you're unable to get and manage the care that you need for your health, that you will develop some sort of long-term chronic medical illness that requires a lot of medical attention and consistency in care. With the use of substances, as we know, that it's never a good impact on the physical self. But because someone is unhoused and they're trying to find ways to cope, substance use allows for them to stay within that survival mode and not go deeper into the mental health conditions that they're experiencing. And then also there's a lack of mental health support. So when you're unhoused, you're stressed. When you're not able to take care of yourself physically, do your physical health, there's additional stress. And then it relies on mental health conditions. A lot of our unhoused population does deal with anxiety or depression. And in some cases, we're realizing there may be a higher risk and behavioral assessments to seeing some sort of either bipolar or schizophrenia due to paranoia of consistently being in survival mode. So those are some of the mental health conditions that we are seeing that can also lead into higher stress on the heart and within their blood pressure. And our environmental stressors, heat. Heat is 99% of every day here in Florida. And even over the last couple of days with the tropical storms that we're having and that we're seeing within the coast, it's increased our humidity by 30%. So just going outside, you feel this stiffness in the air. It's very difficult to breathe. And it can lead to dehydration if you're in that environment every day and you do not have some sort of reprieve to be able to alleviate that pressure on your lungs and on your heart. Your body is consistently trying to overwork itself to stay functioning. And then there's also the fact that our unhoused population experience poor sleep, disturbed when they're sleeping, or they're wake up in the middle of the night due to different sounds. They do not get a full deep sleep. And there's unsanitary conditions, which leads to a whole other set of potential risk factors to someone's health and to the impact on their cardiovascular, on their heart and on their blood pressure. So some of the things that we do see is individual outcomes within CVD and hypertension, which is higher risk of strokes and heart attacks, and earlier within their age. So what we have seen are, especially during our summer months, is a higher probability of heat stroke. We do have, as a current continuum of care within Central Florida, we have a plan to address these issues that we are able to reduce. And I say that in the way I do because we can't control whether or not someone is able to have get the support they need in terms of like preventing a stroke. But if we do see it, we try to educate the community as much as possible on what to do and how to help prevent it. But we can't control like the weather or how many people get housed as much as we would like. And then there's a poor quality of life. You, as someone who is was previously unhoused, there's a difference in the physical state of your being. And when you're dealing with medical issues on top of that, it becomes physically obvious to the trained eye that someone does not have proper care for their own self and that they need additional support. And so trying to support individuals in making that a priority for themselves, it's extremely difficult when their priority is housing. So we do see a lot of individuals with chronic pain, with chronic disabilities, and just the lack of care until approximately 6 months to a year after they are housed. Another thing that we see within our system is our health system is experiencing a massive toll while trying to support our unhoused population. So we are seeing ER overcrowding, especially when it's hot outside. Hospitals and libraries have become what we consider like hotspots or cooling centers throughout the state, where they're providing some sort of reprieve from the heat. But then that also means the body can go into overdrive if they're not there soon enough. And then it just spirals into additional care for the unhoused population. There's also a higher rate of or higher cost of uncompensated care. So if our unhoused population is relying on the ER, then they are most likely not able to afford the healthcare costs that are associated. And then that impacts our system overall. And there's also a difficulty in managing population health goals. We want to see a healthier community, and that's just within our society in Florida. We want to see a healthier community, but we can't do that if we have individuals who are unhoused. And therefore, due to the stress and all the additional factors, they're now having to manage heart conditions and their blood pressure and potentially other chronic illnesses that they are experiencing. Becomes extremely difficult to support them. We do also have how we see a disproportionate effect on different subpopulations within our unhoused populations. So individuals and people of color, our BIPOC community, are more likely to have cardiovascular and hypertension issues, and also are more likely to not have it be diagnosed earlier. So by the time they get to that ER, they may have had cardiovascular issues and hypertension for years, especially if they are unhoused. And then the older they are, it might be a little too late for the type of prevention or I'm sorry, intervention that one would like to see, but now it's maintaining and supporting that individual to try to reduce additional damage to their heart due to having cardiovascular and high blood pressure issues. And then there's also different societal internal barriers that societal and internal barriers that individuals are dealing with. Lack of insurance, the stigma of being unhoused and going to get medical care. And when they're trying to get medical care, that operator bias towards them because they're unhoused, they're not taken seriously. We have seen that within our unhoused population when they go to get treated or try to get treated for different medical issues. And then the consistent criminalization of homelessness has also become a wider impact and has created more implications of lack of care towards the unhoused population. And then I'm going to talk a little bit about like Central Florida and our focus on not Central Florida, but the South Florida. So like I-4 down. I'm not sure if y'all are familiar with that, but it's like middle of the state down, because that's where we're getting most of our data, and that's the counties that are more prevalent in sharing their information. So what we're seeing is about 34% of unhoused individuals in Tampa are currently diagnosed with hypertension. And so that's about 5% above, 6% above overall Florida's general adult population, which is a very high rate of diagnoses. We're also seeing in Miami-Dade County, which is covering all of Miami on the south east coast, that our older unsheltered adults have had high rates of stage 1 and 2 hypertension, but only 16% were prescribed medication. That can lead to an inference of why were they not provided medication. It could have been because of medical bias. It could have been because the individual was not able to get the prescription filled. Maybe they didn't have insurance. Like there's so many different factors that can lead into that when we're seeing such a high rate of individuals have stage 1 and stage 2 hypertension, but not being medically treated for it. And then we also have additional information where cardiovascular disease is actually one of the leading cause of deaths in the homeless population in Florida, where lives are shortened by 30 years, about 30 years on average. So they may not live until they're 90. They may be passing away when they're 60 or even in their 50s because of the lack of care and ability to prevent or maintain where they're currently at within their physical heart health. And then there's additional factors where we do have a very strong smoking population here in Florida. So we do see a lot of tobacco use, which also impacts the heart health and blood pressure. And then we do also have amongst our unhoused population, about 32% are using alcohol or have alcohol use disorder within Tampa. And this also adds into additional stress, poor nutrition, and limited access to preventative care. Even the education regarding cardiovascular disease and hypertension have become very nuanced over the last few years, but that is something that we are seeing overall. And then additional barriers that we see is limited access to consistent healthcare, medications, and safe storage. The state of Florida does not provide any type of legislation to mandate shelters or service providers to have lockers or storage. A lot of providers actually do not provide some sort of storage. What we have seen is that if there is storage, the likelihood of an individual going back to that location to be able to access it is extremely rare. So that's also part of that reason. If we did have more safe storage, there may be a slight increase in individuals being able to keep their medications in a safe place, but that would be extremely difficult with the transient population in Florida, where we do see individuals that are relying on different parts of the state to find housing. And there's also a lack of follow-up on their care. So only a fraction of them are really consistent on addressing the cardiovascular issues that they're having as their hypertension and doing things actively to try to prevent or maintain their current status, or improve their status as well. And then amongst other studies is that homeless patients with heart attacks and strokes are less likely to receive life-saving procedures. And so that's also an additional implication and barrier to long-term care. What that means for the state of Florida is that with our rising unsheltered population, that it makes chronic disease extremely difficult to manage because of all these additional factors. And where we see opportunities and that are that have been implemented are actually really effective are our mobile clinics. So some agencies, instead of having a standalone facility, they are essentially taking what can be equated to like a medical bus, a medical clinic, to different communities, to different encampments, to different service providers to provide them what can be considered like regular care if they have a consistent schedule to go and provide that community, that support. We do have about 3 here in Central Florida, which is amazing. And they take on approximately 2,000 individuals a month of providing medical support. There's also an opportunity for us to have more free or student and educational run clinics, street medicine, and then peer navigators to help work with individuals and support them in checking in on their medical care. So are they going to their doctor's appointments? Do they need to get funding for their medication and things like that? And then there's an additional focus where policies and providers, we're asking for them to work on early detection education, finding ways to provide continuous care for individuals who are unhoused, as well as trying to address all the social implications and determinants of their of the unhoused population. Excuse me. One of the biggest things that we do have to deal with here is weather. It sometimes is our friend, sometimes it is not. And these are different variables that can affect not just our general population, but significantly more our unhoused population. Like how I mentioned earlier, that heat, stress, and dehydration are key factors to whether or not someone's able to take care of their heart. So when someone is unhoused, because they are physically outside in the state of Florida, and it's almost every single day, there's very little reprieve. Our unhoused population have prolonged exposure. And so that can lead to a higher rate of strain on the heart, triggering higher rate of heart attacks, and increasing the strain on the heart. And we definitely do see spikes in blood pressure or maintaining their blood pressure. And then our vulnerable populations, they're experiencing a lot of different things when it comes to not just being unhoused, but the violence that comes with it, being able to access everything that they need in order to support themselves. And you would think that we would have a lot of shade in Florida, but we are realizing that due to development within our communities, we don't have natural shade that would cool down our environment more. So we have very limited access to shade, to water, to cooling shelters. In Central Florida, we actually had a 10% decrease in organizations who wanted to become a cooling center for the summer, which is surprisingly. And then also we are basing off the heat index, which is standard across Florida, which means that if it feels like 108 degrees outside, that's when we activate the cooling centers. And even internally, we were speaking like, why are we deciding 108 degrees? It really should be at, if it feels like 100 degrees, we are opening the doors so that people can cool down. But that is a state policy, not something that we can control, unfortunately. But we are seeing a reduction in cooling centers. And then with everything compounds. You have all of this stuff, then you have hypertension, and then like if you have a genetic disposition to cardiovascular disease, then that also increases your potentially opportunity of becoming someone who has cardiovascular disease. And then in addition to the poor nutrition, stress, potential substance use, everything is amplifying heart strain, the cardiovascular strain. And then there are the additional like disaster implications that happen in Florida, weather-related crises, hurricanes, tornadoes, floodings. If you are unhoused, you don't have a safe place to go. We have tried everything as communities to ensure that our population is at a shelter or at one of the hurricane shelters during major storms. But if there is a tornado, we cannot act as quickly as we can. Because as we know, tornadoes are unpredictable. And we're seeing an increase in tornadoes in Florida during our hurricane season, which is kind of scary as someone who's here and has not really experienced tornadoes. But as we know, they are unpredictable and they are violent and they are destructive. And to be unhoused outside in the heat while it's raining during a tornado, all of that is just so much for one individual to experience. And then with that, the additional limited access to care during a weather, natural disaster, or crisis. It's very unlikely that someone is going to get care when they need it at either an ER or an urgent care. It's extremely difficult. And then the implications of all of this. we do try to do emergency planning as much as we can. We definitely try to have climate adapted outreach. Our mobile clinics are key, especially during these weather events. And if their vehicles are able to navigate some of the like destruction that happens during certain weather related crises. And then hydration programs is a new thing that is starting to come up within the state of Florida, where we have water fountains that are built into buildings that like provide cold water instead of just a standard water tank water fountain with outside temperature water. So to actually provide cold water and make sure it's accessible to everyone, and that the water is clean and refreshing for individuals who are unhoused or who need water, because you can be outside working or volunteering and you can also experience all of this. So I'm going to pause it. I do see some things in the chat, but I do also want to go through the case. So our case study, we have John Doe. John is 54 years old, and in Florida, we are seeing an increase of elderly individuals becoming unhoused. So John has been unhoused in Central Florida for about 4 years. He has not been feeling well, and over the last 2 years, he's been waking up with severe chest pain. So he went to the ER. The ER is like, John, do you have hypertension? And you need to make sure that you are getting treatment for your hypertension. So he connects with a local agency called the Orange Blossom Healthcare Center, and they have a mobile unit. It just so happened a few months later, I was able to connect with them. And with getting consistent care through that mobile unit, he was able to receive low-cost medication, ongoing consistent care, and lifestyle counseling. And I use the term lifestyle loosely because homelessness is not a lifestyle. It is an experience that, unfortunately, poverty is a causation of poverty. And I just want to note that in there. So what we're seeing as a result from this case study is that John was able to stabilize his blood pressure. He was able to prevent himself from going to the hospital on a regular basis. And then he was eventually connected to housing navigation within the 2.5 years post his diagnosis. It is difficult, and it takes an average 2.5 years for an individual to become housed, especially if they are transient and with not being able to get in contact with them. So I do have a few questions for you all. So what barriers can you presume he would encounter while being unhoused that would impact his ability to improve his health?
And Valerie, do you want them to unmute themselves and just answer, or put it in chat?
That would work.
All right.
The medication management, him just accessing the medication, timely and having it readily available for him to take.
That's definitely one of them for sure. And then I am going to pop up in the chat just in case if anybody puts anything in there.
I would say transportation barriers, because it's for medication, but also for everything else that he needs, follow-up appointments, to get to healthy food, so on and so forth. And transportation, I know I'm in North Carolina, but I know in every state, transportation is a big issue, or lack thereof.
Absolutely. Transportation is huge. In the fact that in our Central Florida area, we do not have a strong, actually throughout the state of Florida, we do not have a strong interconnected transportation system unless it's by vehicle and it's your own personal vehicle. I also see in the chat, oh my gosh, y'all are going off in the chat and I love it. Great. Certain medications require ID. Yes. And sometimes you cannot get your medication if you don't have an ID or an updated form of identification. Showing up more frequently to the ER, that is absolutely a barrier. Storage for healthy foods, absolutely. being able to keep food, medication, supplies in essential space that is safe and reliable. Absolutely. So what made his intervention successful?
Having someone like the mobile unit, so someone come to him, so transportation, that barrier was kind of cut out.
Mm-hmm. In the chat, we have follow through. Absolutely. I would also add that John himself cared to do something about it. So playing on to Erica's response of following through, absolutely. I think it is key to see internal motivation to address your health challenges, and then stay consistent with a medical professional or team of medical professionals who care and absolutely express concern over the patient. Absolutely. An additional barrier, yes, absolutely, Jackie. Communication issues. What if John didn't have a phone to speak with the mobile unit? How would he know where they're at? That's also a big thing. And then not being able to follow up with appointments. Jackie, that is key. That's another big thing. And then what made it successful, Benita says, care navigation through the mobile units housing. Absolutely. The consistency is also key to his care, being able to consistently follow through with his medical care. And just a little brainstorming, like what would it take to scale a program like the mobile unit within the South?
Well, first of all, education about it, spreading the word, and then lots of collaboration between and among health and human service organizations to figure out in each community is different, but what resources are already available, what's needed, how they can work together to make it happen in their particular area, and seeing if there's funding that would support applying collaboratively for funding sources too.
I love that. And Rebecca said, building rapport in the communities. You have to build rapport before you can even present the idea of scaling some type of program or creating a program in someone else's community. I love those responses. And I'm going to skip the next question because it ties into the next two slides. But this is something I would like for you to consider is like how to health and housing systems, how can they work better together for prevention? And that's one of the key things is kind of like, where do we go from here? Knowing that maintaining healthcare for someone who is unhoused, they need some specialized preventions. And some of those things that we can do is increasing mobile clinics, shelter-based screenings, and blood pressure checks at every contact point. Now, the last one, every contact point is strong, but it's a good idea, especially in Florida, making sure that we're able to have an opportunity for unhoused individuals to say, yeah, I want to get my blood pressure checked. I'm not sure if everything's okay. And if they have high blood pressure, being able to identify a means for them to get care. So making sure that accessing affordable medications and safe storage options, as well as a team that's supporting them to be consistent. And then we also can do daily supports. So finding a way to integrate heart healthy food into our shelter and food bank programs. Second Harvest Food Bank here in Florida does a phenomenal job working with additional organizations throughout the state in providing heart healthy foods, as well as I believe it's called Harvest International. We have Second Harvest, and then we have Harvest International as well. And then we also really should consider providing hydration, rest, and safe environments that reduce blood pressure stressors. So opening community centers or community cooling centers throughout the state can significantly improve and reduce some of the issues that are related to medical care. And then the most important one is to provide affordable and sustainable housing for decompression. It takes anywhere between 1 to 3 years for an individual to decompress after being unhoused. And what I mean by decompression is starting to get out of that survival mentality and into a self-sustainability mentality. And I believe that is, oh, no, we got one more. Building community voice behind it. So building coordination and voice behind all of the potential interventions. So strengthen collaboration between providers, between housing services and social supports. And one of the key things that I do want to highlight, because I do this on a regular basis and it has proven successful from what I've seen in other communities and in mine, is establishing some sort of lived experience council or board. So youth and or older adults, youth typically have their own council to provide practical and effective strategies and interventions that they can identify for themselves that they would like to see within their community. So those are some really key things. You know, we may come up with ideas, but someone on the other receiving end can say, that's not really what's going to work here. Here's what we need. Something that's right here, right now, versus something that is long-term. Or we need something long-term because you're only providing something right here, right now. And those are the ideas presented. So it's definitely a strong collaboration to find ways of intervention. And that is all. So I want to thank you all for having me. And I know we're going to go into the Q&A. So I'm going to stop sharing my screen.
Well, Valerie, we thank you so much. And we'd like to go ahead and open up right now for questions and discussion for Valerie.
Thank you, Erica.
Thank you so much, Valerie. This is something that I know we encounter and work with all the time with our patients. And one of the things we struggle with is even some of the ones who are staying in shelters is the kinds of food that they have available, which is inexpensive, tons of carbs. So a lot of our patients with cardiovascular disease also having diabetes, and a lot of those foods are being higher in salt as well. So it is a challenge. And wonderful to hear all the things that you were sharing, is particularly the access to care with some of these buses and really going to the people, because access to primary care is really hard, especially with the transportation, like you mentioned. So really wonderful talk. Thank you so much. I don't really have a direct question. I was trying to think of one. You just shared so much wonderful information, so much to think about. Thank you.
You're more than welcome. And one thing I'm also noticing within the state of Florida is that we're seeing more, not necessarily food trucks, but amongst the same mentality as a mobile care clinic is a mobile food bank. So we do have, especially in Central Florida, we have about 2 organizations that are intentionally creating pop-up food banks where they are able to coordinate either at a location or they take their mobile vehicle, their clinic or food banks to different parts of the community and are providing fresh, essentially kind of a farm to table. So it's local produce, local ingredients that are free for the community to take. And they don't have to provide identification. They don't have to provide any type of verification of address in order to receive the benefit of obtaining fresh food for them to eat or take with them.
If you have any questions or comments, please feel free to unmute yourself. Oh,
I have a question that's kind of indirectly related to this. How do the people that are unhoused learn about and potentially access an application for housing?
So in the state of Florida, we use so I love your question. And it can be different for every community. But in the state of Florida, the way we navigate this, our directives come from the Housing and Urban Development. So we have something called a coordinated entry pathway. And the way someone, if they are unhoused, they would call 211 and say that I'm homeless, I need assistance. And it essentially they get put on a callback list from our access team, and they call every single person who gets put on that list and see if they are eligible for any of the programs that we currently offer for housing. And then if they do, will then provide them, kind of like take them to the next step, which we would formally enter them into our HMIS system, so our homeless management information system, so that we're able to assign them to an agency that's managing that program. And then that agency will work to get them, get their identification, whatever they need in order to start the housing process. And then they get assigned a case manager from there. And so it's the homeless response system. Every community has some sort of version of this. The reason why I paused initially is because my brain went straight into the technical part of it, which is it's very complex and can get very confusing very fast. We're still trying to make sure that we are clear on how we communicate about the homeless response system and our coordinated entry, because it's such technical jargon that unless you're within the community getting trained on the verbiage, it's very overwhelming. The youth we work with, they're like, can you change the words? Because we can understand this, or include more visuals, but it can be very, very complicated.
And I'm perfectly willing to admit that as an educated individual, I've looked at the site for South Carolina and it's daunting.
It can be overwhelming. Every community is completely different, but yet it's all the same. It's one of those things where you're just the correlation between community, because we all have to follow the same guidelines. But then everyone does it a little bit differently, but also the same. It's one of those things. And then I do see Julie's question in the chat, like, how do we navigate for the Spanish population? So in Florida, we have multiple populations who speak Spanish, but then we also have a very strong Creole population. And then we also have a strong population within Asian communities. So we do have Vietnamese is the next language right after that. So our community organizations do provide information in all of the languages that they know that they are experiencing of the population. So whether it's a Spanish community or someone who speaks Creole, someone who speaks even Patois or Vietnamese or Chinese or Cantonese, they try to provide the information in as many languages that they know their population can understand or currently speak, I should say. And so it varies. We also, in most of Florida, we do a very good job of hiring a diverse set of staff who are actually able to speak those languages, to be able to support as many community members as possible. Of course, you're welcome.
Well, that's perfect. Thank you so much, Valerie. I honestly think that we are about up for time with the questions and discussion. But I did see that on your slides, you did give out your email address, and The slides will be posted in the iEcho website and also on, right there in chat.
Yes.
So I'm sure Valerie would be happy to answer questions if you have one-off questions that you'd like to ask. So thank you again, Valerie, for such an educational and interesting presentation. We really appreciate you coming and joining us.
Absolutely. And thank you for having me. It was very, very good. Very fun.
Thank you. All right. So, this is actually our last echo session for the year, you guys. Kind of crazy to say it, but we're wishing you guys a happy holiday season, which it does not seem like it should be already, but my goodness, October's in just next week. So, our next echo session is going to be January 22nd. We're going into our 3-month planning stage so we can plan out the different topics and get all of our sessions scheduled and such. So we will see you guys in January. Again, if you have any topics that you really want us to discuss next year, or you have colleagues that you feel like would be great presenters or you want to present, please feel free to email us at the regional collab at constellationqh.org. And we'd be happy to take a look at that. And we've got a bunch of slots open. So this is our new team now. We do have a new person, Benita, and she is our population health analyst. So we welcome Benita. But our team thanks you so much for joining us today and this whole year. We truly appreciate it, and we appreciate all of your comments and all of your help to get Echo up and up to the standard that you're looking for it to be at. So let's just keep growing together. We appreciate this. There will be that post-echo survey coming out at the end when I close down the session. Once you fill that out, you will get your continuing education credit at the end of the year. We email those out. And if you wouldn't mind taking that 8-question survey, that would be amazing. We again just want to say thank you so much for participating, and we love having you guys. And yes, thank you, Sydney, again. Happy holidays. We'll see you guys next year.